Pleasure to be here, and thanks for choosing me to be a finalist. We are developing two products. One of them is called NIAD, and the other is called LTX-608. Before I talk about them, let me introduce myself and the team. I have 33 years of experience in the life science industry. This is my fourth startup, and for the prior three startups, I'm batting 667 as either a VP or a chief in those companies. My co-founder, Dr. Lakmia Chawla, is an award-winning, internationally renowned intensivist and nephrologist. He actually left academia 6 years ago and joined industry and developed what is now an FDA-approved drug that is used in the ICU every day. We have platform technology, and we've confirmed with the FDA that NIAD is ready for a phase 3 study, and LTX-608 is ready for a phase 2 study. We have a lot of other products in the pipeline, but with a 4-minute pitch, strap on your helmets, this is going to be fast. So, patients that are in the ICU there are about 200,000 patients in the ICU each year that experience an acute kidney injury. Could be sepsis, influenza, COVID-19, for example. And when their kidneys fail, they have to go on dialysis 24/7. Eventually, when they circulate blood through this filter, the blood will clot, and they have to throw away the filter and the clotted blood, which increases the need for transfusions. It consumes doctor and nursing time, and it's a pain in the neck. So there are two products that are the standard of care today, heparin and citrate. Heparin is ubiquitous in the hospital, but the fear of heparin is it will always go back to the patient, and doctors don't want to over-anticoagulate the patient. And so in many cases, you can't use it. It's used in about 35% of the cases. Citrate works as an anticoagulant because it binds to calcium. But to use citrate, you have to infuse calcium at exactly the right concentration. If you don't, you'll create a life-threatening hypocalcemia situation for the patient. So to monitor that, you have to do a blood draw every 6 hours to measure ionized calcium. It's a pain in the neck. It requires advanced training. It's not approved by the FDA. It's contraindicated in patients with liver failure, and half of those patients, half of the AKI patients have liver failure. And so, although about 40% of the hospitals can run citrate, it's only used in about 5% of the cases. So 60% of the cases have an unmet medical need. Our product is a small molecule. It's a drug. But we asked the FDA, would you regulate the product as a device, because we're simply using it as an anticoagulant to get blood through the filter in the machine? And they said yes. So it's regulated as a device. Most of the drug comes out through the filter, and therefore you don't risk over-anticoagulating the patient as you do with heparin, and it's not contraindicated in patients with liver failure. So to summarize, by the way, when you use the product, there is less blood loss, fewer filter changes, fewer platelet transfusions, and it's a lower burden on doctor and nursing time to manage that patient. And this is an ICU patient. This is a critically ill patient, so that's much appreciated. FDA agreed to regulate the product as a device. Then we went back to them and we said, do you agree that this is breakthrough therapy? Because there's nothing like this for the patient in the ICU today. They said yes. So we now have breakthrough device designation for the product. That gives us an almost open door policy with the FDA during development. It gives us priority review of the PMA. Here's the real kicker. We get 65% reimbursement from CMS for the cost of the product above the existing DRG.